Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 147 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, OBP, a 67-year-old female patient is admitted to your medical intensive care unit with possible community-acquired pneumonia. She is initiated empirically on ceftriaxone and azithromycin. Her chest X-ray shows a focal infiltrate. OBP is dyspneic on admission, with a respiratory rate of 33 breaths per minute. Her pertinent vital signs and laboratory values include, a blood pressure of 90 systolic 50 diastolic, a heart rate of 101 beats per minute, a WBC of 18 × 10⁻³ cells per millimeter cubed, and lactate of 4.2 millimoles per liter. A procalcitonin was obtained on admission 12 hours after antibiotic initiation and is reported as 0.1 mcg per liter. So my question to you is, considering this procalcitonin result, which of the following would be the most appropriate course of action in this clinical scenario? Would it be A. Discontinue ceftriaxone only, or B. Escalate antibiotics to piperacillin, tazobactam, or C. Discontinue all antibiotics, or would it be D. Continue all current antibiotics? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Continue all current antibiotics. Although procalcitonin is a promising biomarker for the detection of bacterial infections, it must be interpreted within the context of the patient's clinical course. In this case, the patient has clear signs and symptoms of infection, together with signs of hypoperfusion. A low procalcitonin should not be used to guide therapy discontinuation in this case, and antibiotics should be continued to cover the most likely pathogens, therefore answer D is correct, while answer C is incorrect. Because the patient is admitted with presumed community-acquired pneumonia, the combination of ceftriaxone and azithromycin is appropriate right now, therefore answers B and A are incorrect. Let's move to the next question, please. And the next question reads, PDO, a 77-year-old male patient is admitted to the surgical intensive care unit after elective hip replacement surgery. He has a past medical history significant for chronic obstructive pulmonary disease and cannot be weaned off the ventilator after surgery. During the patient's course, he develops signs and symptoms of infection. His vital signs and laboratory values include a blood pressure of 94 systolic 55 diastolic, a heart rate of 114 beats per minute, a body temperature of 38.8 degrees Celsius, a WBC of 18 × 10⁻³ cells per millimeter cubed, and a lactate of 3.2 millimoles per liter. PDO is empirically initiated on intravenous piperacillin, tazobactam and vancomycin. He receives 2 liters of crystalloid for resuscitation. Pan cultures are sent to the lab. His urinalysis results show pyuria-positive leukocyte esterases, and nitrites. Blood and sputum cultures are negative, but urine culture shows Escherichia coli. His urinary catheter is removed, and vancomycin is discontinued. On day 3 of therapy, antibiotic susceptibility results are available. The patient's Escherichia coli is resistant to third-generation cephalosporins with laboratory confirmation of the presence of extended-spectrum beta-lactamases, abbreviated as ESBL. The lab reports the following antimicrobials and corresponding MIC values. Piperacillin, tazobactam less than 2 mcg per milliliter, considered susceptible. Cefepime 4 mcg per milliliter, considered susceptible. Imipenem, cilastatin 0.5 mcg per milliliter, considered susceptible, and ciprofloxacin 1 mcg per milliliter, considered susceptible. His pertinent vitals and labs include, a blood pressure of 110 systolic 70 diastolic, a heart rate of 98 beats per minute, a respiratory rate of 30 breaths per minute, a body temperature of 37.1 degrees Celsius, and a WBC of 9 × 10⁻³ cells per millimeter cubed. So my question to you is, which of the regimens listed below would be the most appropriate antibiotic option for PDO's treatment now? Would it be A. Add ciprofloxacin to piperacillin, tazobactam, or B. Switch piperacillin, tazobactam to cefepime, or C. Continue piperacillin, tazobactam alone, or would it be D. Switch piperacillin, tazobactam to imipenem, cilastatin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Continue piperacillin, tazobactam alone. This patient is being treated for an ESBL Escherichia coli UTI, in which the source of the infection, his urinary catheter, is removed. The patient also has signs of response to piperacillin, tazobactam with resolution of leukocytosis and fever. In this case, given the low inoculum of the infection, initial response, removal of source, and low MIC, continuing piperacillin, tazobactam is the best choice. Therefore, answer C is correct. This choice may only be the case for UTIs, not other sources of infection, e.g., bacteremias. Traditionally, it was widely believed that ESBL infections had to be treated with carbapenems, however recent evidence suggests that beta-lactamase inhibitor combinations are a suitable option. In the era of antimicrobial stewardship, the preservation of carbapenem therapy should be regarded with high importance. Therefore answer D is incorrect. This current culture has an MIC of 4 mcg per milliliter to cefepime, which according to the updated CLSI guidelines would be considered resistant. Therefore answer B is incorrect. Because the patient is responding to the current therapy, combination therapy is unnecessary. Therefore answer A is incorrect. Let's move to the next question, please. And the next question reads, DBS, a 72-year-old female patient is admitted to your medical intensive care unit. She has a past medical history significant for end-stage renal disease, abbreviated as ESRD. She has signs and symptoms of sepsis. Her blood cultures are submitted to the lab. 2 of 2 bottles grow gram-positive cocci. DBS is initiated on vancomycin, and her tunneled dialysis catheter is removed. On day 4 of therapy, blood cultures are finalized to be MRSA. The susceptibilities are as follows: MIC of oxacillin greater than 4 mcg per milliliter, which is considered resistant. MIC of vancomycin is 2 mcg per milliliter, which is considered susceptible. MIC of daptomycin is 0.5 mcg per milliliter, which is considered susceptible, and MIC of linezolid is 1 mcg per milliliter, which is also considered susceptible. The intensivist does a transthoracic echocardiogram, which reveals echo densities on the mitral valve. DBS will be treated medically with antibiotics for 4 to 6 weeks. The patient's repeat blood cultures show currently no growth. Her pertinent vital signs and laboratory values include a blood pressure of 150 systolic, 90 diastolic, a heart rate of 88 beats per minute, a body temperature of 100.2 degrees Fahrenheit, a WBC of 11 × 10⁻³ cells per millimeter cubed, and a lactate of 1.1 millimoles per liter. So my question to you is, which of the regimens listed below would be the most appropriate treatment regimen for DBS now? Would it be A. Continue vancomycin, and target a trough level of 15 to 20 mcg per milliliter, or B. Switch vancomycin to daptomycin 6 mg per kilogram every 48 hours, or C. Add gentamicin and rifampin to vancomycin, or would it be D. Change vancomycin to linezolid 600 mg IV twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Continue vancomycin, and target a trough level of 15 to 20 mcg per milliliter. This patient is being treated for MRSA right-sided endocarditis, with the presumed source from her tunneled dialysis catheter. According to the IDSA guidelines for the treatment of MRSA, treatment with vancomycin of an isolate with an MIC of 2 mcg per milliliter or less should be determined by the patient's response to therapy, regardless of the actual MIC. This patient has responded to therapy with the presumed clearance of blood cultures and resolution of signs and symptoms of infection. Hence, continuing vancomycin and targeting a trough of 15 to 20 mcg per milliliter is the most appropriate choice, therefore answer A is correct. Linezolid isn't indicated for the treatment of endocarditis, therefore answer D is incorrect. Adding gentamicin and rifampin is considered in the medical treatment of prosthetic valve endocarditis, therefore answer C is incorrect. Because the patient is responding to current vancomycin therapy, an escalation to daptomycin is inappropriate right now, therefore answer B is incorrect. Let's move to the next question please. And the next question reads, FTG, a 48-year-old male patient in diabetic ketoacidosis is admitted to your medical intensive care unit. He has a past medical history significant for insulin-dependent diabetes and cryptococcal meningitis. He is HIV seropositive. His current HAART regimen consists of atazanavir, ritonavir, tenofovir, and emtricitabine, all of which are continued on admission to the MICU. FTG's CD4+ count is 85 cells per millimeter cubed. His diabetic ketoacidosis is well controlled, and he is ready to be discharged from the MICU. Before discharge, the patient is noted not to be on any prophylaxis against OIs, so my question to you is, which of the prophylactic regimen listed below would be most appropriate for FTG now? Would it be A. Fluconazole 200 mg once daily plus cotrimoxazole 1 double-strength tablet thrice weekly, or B. azithromycin 1200 mg once weekly plus fluconazole 200 mg once daily, or C. Fluconazole 200 mg once daily plus cotrimoxazole 1 double-strength tablet once daily, or would it be D. Azithromycin 1200 mg once weekly plus cotrimoxazole 1 double-strength tablet thrice weekly? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Fluconazole 200 mg once daily plus cotrimoxazole 1 double-strength tablet once daily. This patient is admitted to the ICU for an indication that is unrelated to the patient's underlying HIV. The assessment of which prophylactics are necessary against OIs depends on the patient's underlying disease, history, and CD4+ count. In this case, the patient has a CD4+ count less than 100 per millimeter cubed and a history of cryptococcal meningitis. Hence, prophylaxis should be administered for toxoplasmosis, pneumocystis jirovecii, and cryptococcus. The best regimen for this patient is fluconazole 200 mg daily and trimethoprim, sulfamethoxazole 1 double-strength tablet once daily, therefore answer C is correct. The prophylaxis for Mycobacterium avium complex is indicated for patients with a CD4+ count of less than 50 cells per millimeter cubed, which is unnecessary at this point, therefore answers D and B are incorrect. Although trimethoprim, sulfamethoxazole 1 double-strength tablet thrice weekly is an option for prophylaxis, it is not the best choice against toxoplasmosis, therefore answer A is incorrect. Let's move to the next question please. And the next question reads, BJB, a 69-year-old female patient with a height of 66 inches, and a weight of 75 kilograms presents to your accident and emergency department with dehydration and acute kidney injury. She is admitted to your medical intensive care unit. According to her past medical history, she recently received an allogeneic bone marrow transplant and has not yet engrafted. BJB has been pancytopenic for 12 days. On day 5 of the MICU stay, the patient develops acute respiratory distress requiring intubation. Bronchoalveolar lavage is done, which eventually grows Aspergillus fumigatus, and the patient is diagnosed with invasive pulmonary aspergillosis. Her current medications include tacrolimus, corticosteroids, and fluconazole fungal prophylaxis. Her pertinent lab values include a WBC of 0.2 × 10⁻³ cells per millimeter cubed, a lactate of 1.5 millimoles per liter, and a serum creatinine of 3.4 milligrams per deciliter. So my question to you is, which of the listed antifungal therapy regimens would be the most appropriate for BJB now? Would it be A. Voriconazole load followed by 300 mg IV twice daily, or B. Caspofungin load followed by 50 mg IV once daily, or C. Isavuconazole load followed by 200 mg IV thrice daily, or would it be D. Amphotericin B 50 mg IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Isavuconazole load followed by 200 mg IV thrice daily. This patient has invasive pulmonary aspergillosis. Usually, the treatment of choice is voriconazole. However, in this case, the patient has acute kidney injury with a creatinine clearance less than 50 ml per minute per 1.73 meters squared. According to the package insert, voriconazole is contraindicated in this case because of the possibility of accumulation of cyclodextrin, the intravenous drug carrier for voriconazole. Although the clinical relevance of this accumulation is controversial, continued use of a contraindicated therapy is inappropriate when alternatives may be available, therefore, answer A is incorrect. Isavuconazole is a new triazole that was found to be non-inferior to voriconazole for the treatment of aspergillosis and has improved water solubility, which does not require it to be formulated with cyclodextrin, therefore answer C is correct. Conventional amphotericin B may be a reasonable choice, but it will likely worsen the patient's acute kidney injury, therefore, answer D is incorrect. Echinocandins are not the ideal therapies for invasive aspergillosis and should only be considered if there are no other treatment options, therefore, answer B is incorrect. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 148.